on all of our streams. Hello, everybody. Boyd here, your webmaster host, along with Alicia and Jennifer. Hope everybody's well. How you doing, Alicia?
Doing great. Texas is beautiful today.
Awesome.
Just
Jennifer?
beautiful.
We're rainy, but I'm still doing good. So. Got to keep that sunny spirit, right?
Let's show off our CCO shirts.
Yeah, hey, we're triplets. Woo, we look good.
Looking good. You might notice that I have a beard. I'm kind of curious about my COVID-19 whiteness and how it looks like at almost 55 years old. I'm going to be home for the first time in my birthday, which is April 26th. I'm not saying I don't need anything.
Happy birthday.
But I'm just saying.
Now that we know it's April 26th.
I don't know what to do with myself because I'm usually working always on my birthday. So yeah, we're having fun.
Thank you, COVID.
The April 2020 CCO Q&A webinar with your host Boyd here and Alicia and Jennifer, our resident CCO coding experts. And we are going to be talking about all things medical, business, certification, medical coding, billing, and practice management related today. If my kids don't come in from the background and disturb us, I don't know how about you guys are doing.
I locked the door.
Yeah, they're watching a movie in the other room. Yeah.
Let's just make sure that everything's going okay. Good. So welcome if this is your first time to the CCO community. For those of us who are here for the first time, we're going to hear from you in a second. Alicia, just know the polls are kind of in, just make sure you're picking the right polls as you go. We cannot hear you. We can always hear you in the chat though, or see your response, if you will, in your chat. So please use your question box if you've got something to share with us. And please stay to the end. We're going to talk about that in a second. So how many CCO webinars have you attended? We want to find out right now.
I'm going to look for it.
Let's see.
Here we go. So your choices. First time. Woot woot. Let's see. Back for more, repeat offender, liking it here at CCO, and CCO frequent flyer. I already see several names that I recognize. So that's, ooh, my, look at that. It's already 42% frequent flyers, 10 or more. And you guys are on top of it now because you are like pumping in those names. Okay, so I love counting it down like Boyd does, so I'm going to do that. 5, 4, 3, 2, 1. Boom. Okay, I closed the poll and share.
What was that number after 5?
4. Yeah. Sorry, you're making fun of the way I talk.
So first time, woot woot, 20%. Back for more, 1 or more is 6%. 2 to 5, 26%. 5 to 10, 9%. 10 plus, 39%. The big winners here tonight. Thank you guys for being a part here for CCO.
We have a couple first timers in the chat as well. So welcome everybody.
And hide the poll. It was very interesting. It stayed, my camera at least stayed on during the poll, so I was able to go through the slide there. That was fun. Okay, so if this is your first time, we have a little agenda that we're going to go through. We have 3 questions from each of our wonderful ladies here who have presented here many times before. Jennifer, what are you going to be covering tonight?
Well, we had a question come up about how to do a nurse visit in 2021 when the rules change. A question about psychological and neurological screenings and the CPT codes used, and about insurance questions on the CPC exam. So,
yeah, and lucky me, found a risk adjustment question that came up. So, whoo, I grabbed that one. Understanding a RAF score. It's all about risk adjustment. And then pacemakers and ICDs. What's the difference in those? And then wrapping up in coding healed ulcers. Good. And I got you some pictures too.
Nice. Again, Webinar's going to go for about 60 minutes. We're going to go till about 30, well, whatever. It's about 9:30ish. We're Eastern and we'll be finishing up, and then we'll stay for your chat questions afterwards. We're also going to be doing a drawing for prizes that we'll talk about here in a second. And we're going to take your questions from the chat, those that we can answer at least on the webinar. Otherwise, we'll put those into the hopper for other webinars or sharing of all the other kinds of webinars that we do.
Yep.
But again, you can ask a question anytime.
Yeah. These questions all came from you guys. So.
Yep. What is this giveaway that we do, Alicia?
Well, now, if you've been to the webinars before, you know that every single time we do a monthly webinar, we give away a prize at the end. And you have some choices. You can do a 1-hour phone session with one of us. You can do a Blitz package, or you can get a year of the CCO Club Basic, which is actually an amazing value. So again, you got to stay till the end, and then they do a random drawing and pick a name and announce it. So again, pay attention, and if you're here at the end, good luck. Oh, can I talk about the CCO Club?
Of course.
Yeah, well, it's fun. Let me tell you guys, first of all, the questions that came in, predominantly they are taken from the CCO Club members. And then we also have other people that send in questions, but the club members get, seniority, priority, seniority, priority. So it's a great way to have your questions answered by subject matter experts, not just us. It's also an excellent way to pick up CEUs, and there's extra support if you're taking one of our courses. And I wanted to do a shout out for our pathophysiology course, as well as our pharmacology course. This would be a great time to take advantage of those courses. Yeah. You can go to the CCO Club /club. Oh, we got another poll.
Yep. What is your status in a medical coding, billing, or similar medical business related job? Kind of want to see who's on the call tonight. So find out.
Let's see. Looking at medical coding as a career, you're certified and looking for a job, you're already employed, you want to improve your current job situation and earn CEUs, or no, but not pursuing employment at this time.
Our friends in Facebook and YouTube who are watching the live stream, unfortunately, we can't give you access to the poll, but you can certainly put in your status, which some of you have been doing in the past poll, into the chat questions there, the chat area.
Yeah. And it'd be a good idea to let other people know too. If today you find this helpful, feel free to share and both in LinkedIn and YouTube, you can share the webinar. So we are right at 70%. So I'm going to count down so that you can make fun of the way I talk. Ready? 5, 4, 3, 2, 1, bam. Okay, I exaggerated 4 a little bit that time. 4. 4. So sharing now. Did it share? There we go.
Yeah. Yep.
Wow. Improve my current job situation.
I'll read them off for those of us who maybe not can see this. Looking at a medical coding career, there were 11%. 22% were certified and looking for a job. 31% were employed already. 35% improving my current job situation and earning a new credential. And 1% no, not pursuing employment at this time.
Wow. You know what? That improving your job, remember when I said that pathophysiology and our pharmacology courses, and we also have a course in compliance, whether you sit for that credential or not. It's an excellent study. So if you got a little extra time on your hands, there's always a sale or something going on. Take advantage of your time. Don't let the whole COVID pandemic slow you down. Oh,
everybody's safe out there, by the way, and practicing social distancing. I know people at Menards aren't, so
What we thought was really funny is on base at the pharmacy, when you go to the pharmacy, they've got the little footprints to stand 6 feet
Yeah.
apart, except they have 2 lines and they're right next to each
So
other.
they're side by side.
We're like, okay. What?
I think that masks will be, I saw someone do some fancy masks or something the other day, so that's going to be fun. So.
Yep.
Looks like Jennifer gets to go first. Lucky
This is
her.
not my question, though.
Enm nurse visit.
Nope, this wasn't my question, though. So if you just pull up the answer sheet,
Okay.
you'll see what the question was.
Oh, on the thing.
Oh, no,
Okay.
no. Oh, no, you're right. I don't know what I'm reading. Okay, this is... I think the outpatient in a capital letter got me confused there.
Well,
So
we can code that if you like have a stroke or something.
no. Just forgetful.
That's
just
terrible.
forgetfulness, old age. That's an F code, I know, but whatever. So how are we going to be able to do nursing time when we don't have a specific CPT for it if they're currently using 99211 in 2021? How is this going to change? Well, I think there's a little bit going on there. And yep, there's my question right there. I don't know why I didn't recognize it. So in 2021, when we start leveling the Enm Encounters, they are going to move from our current protocol that we have of doing history, medical decision making, and examination. So they're going to move it to medical decision making level or total time. So as the medical decision making takes into account establishing a diagnosis, assessing the condition, or the risk involved with the patient, those aren't really what a nurse typically does in their scope of practice. Typically that 99211, you're just coming in for an injection kind of thing or checkup of some wound or maybe take a stitch out, some kind of minimal type of follow-up visit. But there may be some confusion because 99211 still is an eligible code in 2021. It's 99201 that's being taken out. It's not used very often, so 99201 is going to be removed. 99211 will still be there. So if you currently do use a 99201 for some reason, the guidance suggests you're going to bill it as a 99202 now. So that time limit will be based in the 99202 now. But we'll just go over what some of those changes are just so we can look at them all again. So they no longer have to use the 3 components of history, exam, and medical decision making. They won't be the key components anymore. They can still be performed because that's how the doctor or provider is going to make their medical decision-making process. So when we're basing the codes off of medical decision-making, you still kind of need to know what's going on, how this happened, what other things might be involved, looking at the history, looking at the exam, what kind of problems are they having, is there stomach problems and chest problems, they're still going to have to kind of interpret all that information. So it's still going to help in that medical decision-making process. It's just not going to be the key components that we're going to base coding off of. So time is going to change from face-to-face time. It's currently time in the CPT manual is currently defined as meaning the time spent with the patient, or actually they use it as, when they say time, if you want to use time, it's the counseling and care coordination has to dominate the visit. And some MAC carriers through Medicare have indicated, yes, we do base on that, or no, we don't. It depends on the MAC carrier. But in 2021, that definition is going to become total time spent for the encounter on that day. So currently it's face-to-face time. So if you were in the room from 11 to 11:08, you were there for 8 minutes, face-to-face time. That's going to change. So it's going to be if we did the time spent in coordinated care, that's no longer going to be required, because that's all, if we take a look at what the total time of the encounter includes, that all becomes part of the encounter. So preparing to see the patient, whether you have to look at some tests, maybe they're coming back for a follow-up to see what their MRI said, or something. If you're looking at the old information, kind of judging and getting your opinion of the patient, obtaining the history, performing an appropriate exam, that's still going to be part of how they make their medical decision making. It's just not a key component. Counseling and education, you can still do that. Ordering medications, tests, procedures, the individual interpretation of a result or independent interpretation. So if you're, in my field in orthopedics, the doctor's looking at the actual MRI. Yes, they have the report, but they're reviewing the MRI for themselves to see if they see anything in there. That's all. You think of how it is now. If you know your E&M levels very well, that's one of those little the data key points that we get for determining medical decision making. That's all going to be encompassed now as part of an office visit. Referring or communicating with other professionals, another data point as well. Care coordination, documenting in the health record, of course. That's all what they mean by the total time spent in that encounter. So all of those things that are done to help a patient before they get there, while they're there, after they leave, that's all going to come into that. And that's what time is going to mean. Now, medical decision making, or MDM, is what we refer to it as. There will be some adjustment as well. So the table is going to change. There are now some options for the diagnosis and risk, and the wording is going to change some. So currently we have number of diagnoses or management options. That's going to change to number and complexity of problems addressed. Because remember, we don't care that they had a hip replacement 10 years ago if they're coming in for chest pain. They're probably not related. You're not treating the hip if you're looking at their chest pain. So we don't care much about that. We're looking at the problems addressed. The amount and or complexity of data to be reviewed is going to become amount and or complexity of data to be reviewed and analyzed. What are you doing with it on that day? Not just that you looked at it. How is it part of the process? And then finally, our risk or complications and our morbidity and mortality becomes risk or complications and or morbidity and mortality of patient management. How do those things affect what I'm doing to the patient today? So I took a small snippet of the table just so we can kind of see. This table is the MDM table. We have some options on there. So we have low, it could be 2 self-limiting problems or 1 stable problem or 1 acute uncomplicated problem, or we could go by the amount and complexity of data, category 1 or category 2. I mean, there's a lot of options in there now. It makes it a little bit different than currently we have what ice, bandage, kind of option. So we're looking at how we're assessing that medical decision-making table. I also took another snippet of what those new codes are going to look like in the 2021 CPT manual. So 99211, it will still be there. It is for evaluation and management of an established patient that may not require the presence of a physician, usually presenting problems minimal. Notice there's no time involved in that one. It's just a minimal, it's still going to be kind of the same idea. Where 99212 is changing to say, appropriate examine a straightforward medical decision making. When using time, this is 10 to 19 minutes. So we can see how the code are changing just a little bit. And this information was all taken from the American Medical Association. That link on the bottom is this all laid out. I think it's 16 pages. The tables are there. The new codes are there. Talks about prolonged time as well, codes for prolonged time. So this is how the office visits are going to change. So I think there was a little bit of confusion in the question. That 99211 is still going to be there, but 99201 will be taken out. So.
Very nice. And they wanted to know, did you get a new credential? That one on the end, CEMAO? I'm not sure what that is. You'll have to tell them.
Certified Evaluation and Management Auditor for Orthopedics. So that is through NAMAS.
Cool.
So that's a NAMAS credential.
Ooh, a NAMAS one, yeah.
Yep.
Oh, well, this is a good time to tell you guys that we're having a sale. It's on all courses and the Review Blitz, 30% off, and that sale is going to expire on the 25th at midnight. Real easy to find the sale and the information. Just go to cco.us/CCO sale. Also, again, those 3 courses I mentioned, compliance, pathophysiology, and pharmacology, excellent ones. They're not very expensive. So, you know, what a great value. And then to get 30% off of that, you know, that's what I would check out if I were you. Oh, right. Me. That's terrible for me to say that, right? But this is a subject I absolutely love, guys. The question came is why is it so hard to figure out how a RAF score works? I just now learning to do HCC coding and want to get my CRC, but this does not make any sense to me. Is it really important to understand if I want to get my CRC? I'm very good at coding ICD-10 codes. Thanks, Brenda. You know what, Brenda? You're going to be able to get this because I enjoy talking about it. Let me just get this answer sheet over here. It's not as hard as you might think if you understand why it's being done. At least that's what helps me. I am not one that likes to work with numbers, and which as a coder, that seems kind of odd, right? But we don't do math particularly, you know, maybe with lesions or something. First, let's just reiterate, you know, what is an HCC? It is a hierarchical condition category, and we use those in risk adjustment. So it kind of makes the hairs on the back of my neck raise up when I hear people say, oh, I'm an HCC coder. Well, no, you're a risk adjustment coder, and you code HCCs, you capture HCCs. Anyway, so I always like to tell people, you know, don't tell everybody that you're an HCC coder. You're a risk adjustment specialist. And what CMS does is they use these HCC category codes to give value to diseases, chronic conditions. Now, CMS uses CMS HCCs, and since this has worked so well for CMS for all of these years, then Medicaid started doing it, and that is HHS HCCs. So for the most part, it's the same process, except for there's a few little nuances in there where HHS does stuff within the year, and they don't do just chronic conditions, and CMS does chronic conditions for people 65, you know, Medicare patients. Some Medicare patients can be under 65, but again, that's another subject. So they've been doing this model since before 2000, but officially started using it in 2004. It's been going on a long time. What happens is those HCCs carry what we would say weight, and that is a value. Okay, so when we say weight, I think of it as if you have a lot of coins in your hand, that's a lot of weight, right? The more the more expensive your car, the more weight that it's involved in value. That's how I think about it. So the higher the weight score or the score for the patient, then the more money that's set aside for that patient's care. Why? Because it costs more to take care of them. Now, there's other things that are factored in besides the chronic conditions. They get a base score for their age and if they're male or female. Okay, so there's some demographics involved as well. Now, why is it important that we get to the highest specificity? Because, for example, if a person has diabetes with no other complication, that's one score. But they get a different score, it's a different HCC, if the patient has diabetes with a complication, because they have a complication. It just makes sense. It will cost more to take care of and treat the patient that has a condition, a comorbidity, than it would be with somebody that's, just has diabetes. Anyway, that's all done in a score. And there's an equation to it, which I've got some examples for you. This is two different patients, two females that are the same age, but they have a difference of $13,718.40 in a year. Okay, so let's look at Miss Betty Blue. She's 72 years old, and she gets a basic score to start with on her age and gender, the demographic aspect, and that's 0.386. You notice the second person, Miss Connie Carmel, you like my names? I thought those were creative. She is also 72 years old and a female. So again, their basic score that they start out with, it is the same, is 0.386. Now, for example, you don't have to have these scores memorized. There is a graph. You go to CMS. They've got all of this in there. It's kind of like on an Excel spreadsheet. So again, they both start out the same. Now, if this was a man, then it would be something like 0.308. Okay, but it's based on male or female, and also whether you're institutionalized and so on and so forth. But same score. We start out flat score the same. Now, if Miss Betty Blue is a diabetic, then E11.9 for just basic type 2 diabetes carries an HCC of 19. And when you go look up the score for 19, then it's 0.105. Okay, so we get to add that to 0.386. And then she has COPD. So J44.9 carries an HCC of 111. And then that is carries a score of 0.335. So you add those up. You add those three up, and it comes out to 0.826. Really simple. Okay. Now you think, well, then how do you get that money at the bottom? Ultimately, the scores start out as a 1. Okay. So the basic score is a 1, and then that averages out to like $800 is what they say. So you take the 0.826 and you times it times 800, which would be a 1, right? And then that gives you how much a month, okay, that the provider would get for that patient for these conditions. Pretty simple. Okay, then you need to know what it is for 12. So then you just, for 12 months. So you just take that total times 12. So it's 0.826 times 800 times 12. And they are going to give almost $8,000 in the coffer to take care of Miss Betty Blue, based on her being a 72-year-old female having diabetes and COPD. Okay, now let's look at Miss Connie Carmel. We started out the same, 0.386, but she's got some other things wrong with her. She is also a diabetic, but notice that she has a comorbidity. She's got polyneuropathy, and that carries a score of 18, not 19, and that's 0.302. So it changes a little bit, and that's why you want to make sure you capture any comorbidities. If they had just captured, type 2 diabetes, it would be a 19 and it would be a lower score. She also has COPD, so we've got the 0.335, but she also has a pacemaker, and that risk adjusts at a 186. Okay, so that gives her a 0.832, and she has breast cancer, and that risk adjusts, gives you an HCC of 12, which translates to 0.15. And then on top of that, she has a BMI over 40. So if you have a BMI of 40 or above, then you get to count that. That has an HCC, and it translates at 0.25. So then you just add all those up. Now, Betty was a 0.826, But Connie is a 2.255 because she has more things wrong with her. It's going to take more money to take care of Connie than it will Betty. So then you have the 2.255, you just times that times the 1 or the 800. That gives you how much a month, and then you times that times 12, and it's $21,648 goes into the coffer, set aside to take care of Connie. Now, you can see if we didn't capture the pacemaker, we didn't capture the BMI, which you probably, you probably wouldn't leave off the cancer. That'd be easy to cap, but if you miss the BMI and the pacemaker, that's a significant drop. And what if there's a malfunction in the pacemaker? I mean, they have to come in constantly to have things taken care of the pacemaker, right? There's, and then BMI, obesity, this is morbid obesity, 40 and above. Lots of conditions. So ultimately, it's, really easy to figure out this RAF score. And between these two patients, now we know there's, almost a $14,000 difference in money that's set aside to the provider. Why does this make a difference to the provider and that they capture the highest specificity? Not only will there not be enough money to pay the provider, but the MA plan, if you keep giving everybody lower scores, like $8,000 instead of, 20, then they're going to get upset. The MA plan will start noticing there's a deficit, and they'll go root out where's the problem. Oh, you're not capturing all the HCCs, so they'll just drop the provider. Or they'll penalize them and charge they won't get as much money. So again, it's really important to do that. It's good to not only in risk adjustment to SDK. So to answer the questions, and that's how you figure out a RAF scores. If you are a coder for an MA plan, you're probably just coding chronic conditions. That's it. If you're working for a facility or a provider's office, then you're probably looking at RAF scores so that you can keep the provider abreast of, how they're doing. So fun stuff. I love this kind of stuff. All right.
She's so funny. He calls that fun. It's
you
math.
guys need to. You need to. I hate math, but this makes sense to me, so it's okay. But again, you guys, any type of risk adjustment question, I'm there. I love those. And Jennifer really loves billing questions. And again, she's an ortho specialist. She's auditing them now. Hey, we got this great review came in, and we really appreciate when that people let us know how our products are helping you. And so this one just came in, and it said, the BAT system really helped. Thank you so much. The BAT system really helped me, and so did your time management techniques. I stuck to them until the end, even when I started to panic and passed. Heidi G. So nobody's testing right now. We know that. But thank you for continuing to let us know that our products are helping you, and we want you to share that with others. We don't really advertise. We do word of mouth. That carries more weight than a RAF score. No.
What are they saying about testing?
What?
Will they ever do online testing, or what will they do?
AAPC does not. The one I just did through NAMUS, that was an online test. I had a remote proctor. I had to show my video camera all around my room under my desk, kept everything off my desk. I had to, so I had somebody watching me the whole time. I couldn't see them, but it was videotaped. So whether they go back and do it later, there are some organizations that do online. I know AHEMA is mainly online, but you have to go to a testing center for theirs. So whether they've changed some of their rules to use a remote proctor, I'm not sure. So,
and AMBA too for billing.
Theirs is online. They have a billing and a coding certification, and theirs is online. Yeah. We did have a question about the BAT technique. What is an example of the BAT? So BAT is bubble highlighting and annotation technique. So it's going through that CPT manual and there's a technique to bubbling and highlighting. You know how you have your family of codes and then you've got your subsets, and so it's a way to draw out the information and make it remarkable to you, especially during a time test. So
yeah, speeds you up, and also it the BAT system includes the time management techniques and Laureen came up with these in like 1990, I think, and been going strong with it ever since. So it just continues to be improved as we go along. And if you're curious about testing, stay to the end. We'll talk about that a little bit more if you have questions, but we'll let you know when people like the AAPC make decisions and announcements. The club members will know about that stuff first.
And it is, I notice on the forums, AAPC forums and stuff, people keep saying, when is AAPC going to do it? Well, it's not all up to AAPC. So a lot of it is the chapters that host the exams. Now, I use the college campus for our chapter exam, I use the college campus that I teach at, because they give us a benefit of being able to use the room. Well, they just this week announced they're not even opening again until the end of August. So we can't even use their facility at all till maybe September. So everybody's pretty much in the same boat, whether chapters use a library or a school or a hospital facility, conference room, all of them are going to have those restrictions out there. So unfortunately, it's not AAPC mandating this. It's the chapters and their availability to have an exam, and you can't hold them in somebody's house. So you can't open up your garage to have an exam. So
in the chat, it's saying that Mary says AAPC is currently looking at testing virtually. I have a friend that is taking the BAT and states that she is bubbling her book like crazy.
Yep, that's what you need to do. Get it all
especially
ready.
Right now, you got time sitting.
What does AMBA mean?
American American Medical Billing Association. Great organization, leaders in billing.
Yep.
All right. Okay, Jennifer, we're ready.
Yes. All right. So we had a question come in, and actually this was a rather lengthy question, and I kind of broke them into scenarios. So pretty much, what are some examples of billing for psychological and neuropsychological screenings? So they had more to the question, so I kind of broke those into a scenario, and then I will discuss each of those parts. So their first one is they said, well, what if a patient comes in and we give them an iPad with several screening questions prior to being seen by the physician, and the responses are automated, and then they're ready for the physician for when he can see the patient. So they think that would be coded with a 96146, but they're getting feedback that that's just for a single test and can only submit it once per visit. So the code description is with a single automated standardized instrument via electric platform. So electronic platform, iPad, okay, makes sense. Single automated standardized test. Or with 96138, psychological or neuropsychological test administration and scoring by a technician, 2 or more tests, any method for 30 minutes be more appropriate. Well, a 96146 does describe a generation of a test with automated results. That is limited to 1 per day. It's not 1 per test. It's not, I bill it at 3 units because I gave 3 tests. So there are certain things to look at specifically in those terms with CPT's descriptions. And 96138 is for test administration and scoring by a technician, although there is no defined verbiage of what a technician is, of 2 or more tests using any method. The code is time-based on the first 30 minutes. So of course we have our threshold of at least 16 minutes has to be done with that technician performing that test. So it's not automated. It's not that same as that iPad, giving them an iPad and they answer a bunch of questions. So tests that are used in a 96138 typically would be like a digit symbol substitution, Stroop interference test, trails, immediate recall and delayed recall, those are quite involved tests. That's why they say like the first 30 minutes, and then there's an add-on code for additional time. When I did some searching on this, of course, I went straight to the APA, the Psychology Association, and they, had scenario examples as well that these people could be doing these tests for 6 or 7 hours. This is long. These are very involved tests. So it depends on that iPad assessment is one assessment. The 96146 would be appropriate if it was an automated test. If it gave all the information, it just kind of spit out your information, everything's all automated. 96138 would need to have 2 or more, but that integrates a lot of times. What I was finding out is that takes also like works with your record system. It kind of integrates the information and comes up with an assessment. They asked a different question as well. What if the screening shows something that the physician then covers with the patient? So they took this test on an iPad, it's ready for the doctor looks at it and has other additional concerns. So they're thinking that could be a 96130 for psychological testing evaluation or 96132 for neuropsychological testing evaluation. Then would the physician have to document the time? Now, 96130 and 96132 are codes that describe services performed by a physician or, of course, we know other qualified healthcare professional, but not your clinical staff, so not that technician, whoever that may be. The time requirement is at least 31 minutes because this is an hour code. And included in those codes, according to the American Psychological Association, is selecting the tests, integration of their patient data, interpretation of the test results, and your clinical data that comes from, assessing the patient as well, clinical decision making, treatment planning and reporting, and interactive feedback with the patient and family. So we can see this is very involved. This is not just, I answered some questions on an iPad, and here's what I think. A 96130 and 96132 are very involved. This is like, think of it like a doctor doing your assessment. You've got the whole history, the physical, your medical decision-making, exam. You've got all these components that come into it. So the medical records need to indicate, I read that they need to indicate that face-to-face time with the patient. So what time did they spend with the patient? But I want to clarify something here. The wording said screening. So they're wanting some screening scenarios. There is a difference between screening and assessments. So these tests that we discussed, that I said 96130, 96132, 96138, those codes, those are used by psychologists and neuropsychologists to administer and review. So one thing that we sometimes don't know in these questions when a question is submitted, who do you work for? What kind of doctor do you work for? Sometimes the state's important, but where you are or what kind of facility it is, but what kind of doctor is this? I'm not sure. So they gave a patient an iPad, and is this a primary care doctor? Is this a psychologist? I'm not sure. So I wanted to try and give as much description as possible in these codes so that you can be more informed in case that scenario fits in your office. So a screening test that might be given by your primary care doctor, that's something different than what we're talking about here. So during visits like the annual wellness visit, the Medicare's annual wellness visit, certain elements have to be performed in order to bill an annual wellness visit code. And some of those, and 2 of them, are to detect any cognitive impairment and review the potential risk factors for depression. They do want those screenings performed, but those are done with a few simple questions, possibly a paper form, possibly having them answer a couple questions, either on a tablet or a form. But remember, screening is just kind of brief. You're not going in depth. So those would be like screening for Alzheimer's or dementia or depression, and they use a form like a PHQ-9 for a depression screening, and that's just a little 10-question, one sheet of paper, 10 questions. So it's not that involved, and of course you can see it's not going to take 30 minutes, it's not going to take 16 minutes to do something like that. So when we bill for the annual wellness visit, we don't code those screenings with an additional code. They are part of the annual wellness visit. They're integrated in the annual wellness visit code. So those tests conducted by 96146 and 96138, they are different than what you're giving in an annual wellness visit. So those screening tools are like the Montreal Cognitive Assessment, Mini-Cog, or Mini Mental State Evaluation, that you're going to use at one of those screenings with a patient in the annual wellness visit. So they're just very minor tests or minor evaluations. And if the provider says, well, I think this might be a problem here based upon what the family's reporting and what the patient said and the questions I asked them, I'm going to refer them on to a psychologist now. The part of that annual wellness visit is referring them on to making sure that they are staying healthy throughout all their years of obtaining Medicare. So they might now refer them on for additional testing. And then those more advanced tests are what you're going to do with the 96138. So what primary care might do is if they see a patient and they ask them a couple questions about depression screening or a couple screening questions, they can bill a 96127, not part of the annual wellness visit. Say they came in for some total other reason, an office visit, and they wanted to bill 96127. Or Medicare, you'd use the G0444. Now, Medicare does offer a lot of information on their website about the annual wellness visit and about all the assessments that can be done. They even have links to examples with other sites that you can use their forms. You can get more information from. I love Medicare's site and I talk it up all the time. I think it's a great resource. These are two other resources I did find. If you do psychology and neuropsychology evaluations and testing, the first one is a great PDF of, I think it's 30 pages or something. So it's a lot of information and it details everything. It gave you scenarios for the codes, describes what the doctor should be doing, who can be doing it, everything. So it's a great coding and billing resource if you do psychology testing. The other one is more of what these neuropsychological tests are. So if you don't think you're performing, if you're not sure what the test is you're giving a patient, what code it should be, if it meets the 96138 or 96146, it will be described in these neuropsychological tests. These are very involved tests. So we can see why it would take a long period of time to perform some of these tests. So to answer the question, the impression I received from the question was screenings, which can be part of your visit already, could possibly meet that depression screening or mental assessment screening code that's offered, but a psychological or neuropsychological testing assessments are done by psychologists and neuropsychologists. So if you're in that field, there was a great resource there, and you're probably more familiar with all these codes, but a primary care doctor or a family doctor is most likely not going to be performing those types of codes with those types of tests with those CPT codes.
That's good stuff. Yeah. Hey, we got another poll. What is your medical background? Now let's see. Some of you should tell us if you're in psychology, right? So let's see. I hit launch. Oh shoot! I closed it. Yeah, but I think I hit it too fast and closed it. So it was clinician, provider, coder, other, or none. And I don't think I can go back and do it again. Let me look and see.
Nope.
No.
Looks closed.
I'm sorry.
Okay.
I accidentally clicked it twice.
Okay. Let's see if we
Bummer.
get another one.
Okay,
Um,
let's pick, would you like to listen to a
Court coding
podcast?
No, how about court coding credential do you want next? Or work status? That's
I
one
already
we.
hit the other one.
Okay, fine.
I don't want to mess up another one, boy.
So what court
Okay.
credential do you want next? CPC, CCSP, or that's option 1. COC, CIC, CCS, option 2. Option 3, CPMA. Option 4, CRC, or other. And put in the question box what other is for you.
Oh, my word. CPC and CRC is neck and neck. Come on, guys. Some of you got to want the CRC because it's just awesome. We've got some CPMAs and CPCOs in the chat area. And so, you guys, we have a course for compliance, the CPCO. But I think everybody should take the compliance course because it involves everything that we do. If you have a credential, it's just one of those that you should have under your belt. All right.
Sarah, over in YouTube, what is other for you? Let us know, Sarah, over in YouTube.
Yeah. What's other? All right. I'm getting ready to close. I'm going to count it down because I know you like for me to say 4. So it's 5, 5, 4, 3, 2, 1, bam. That's so
That
much
one
fun.
wasn't as exciting.
No, 4. Oh, you know what? Look at that. CPC and CRC, 28, the
Sure.
same.
I can't see them.
Oh, sorry. Share. Sorry.
They came in the same.
Yay!
CPC
Other,
and CRC at 28%, followed by other at 22%. So that's good. Expanding
Graciela
it.
says CDEO. Good for her.
Oh, yeah.
Yeah.
COC,
That's what-
CIC, CCS is 14%, and CPMA, our auditors, are 8%. All right.
14
Oh,
is exactly half of 28 too. That's interesting.
yeah.
We had an
Oh.
even number then. That's
Yeah, that's interesting. All right, we're ready for another one. We're going to talk about pacemakers and ICDs, and that does not mean ICD-10. We had a question came in that says, "What's the difference in the?"
For a second, I don't think.
Oh, hide it.
There you go.
Hide
Okay.
it. Thank you. I just got so excited. So, what is the difference in a pacemaker and an ICD? The coding for these seem very confusing. Well, it can be a little confusing, but I think I've got some good information for you. This is another thing I like to talk about. But then again, if it has something to do with coding, I like to talk about it anyway. So, makes me happy. Ultimately, why do people get pacemakers or defibrillators, internal defibrillators? It's because they have an arrhythmia. It's a treatment for an arrhythmia, an irregular heart rhythm. And you'll notice that they'll have like AFib or A-flutter, in their file or in their chart. They may have tachycardia, bradycardia, but they'll definitely have a lot of EKG strips. So first, let's talk about a pacemaker. Ultimately, the reason a person will get a pacemaker is because of a few things. Either they have too slow of a heart rate, or it's just uneven. We need a steady, even beat. I think of a jogger. If you start out too fast, you burn up all your energy, and then you peter out and can't finish the race. If you start out slow and steady and you wait too long to give it that burst, then again, everybody else will pass you up. So you want a slow, steady, even to pass the race, like the tortoise and the hare, right? And you could also have had an ablation procedure. Ultimately, what they do with that is they'll go in, and ablation just burns off a part of whatever tissue. But they'll do that in like the SA or VA node. They'll burn off some of that tissue, and then the heart won't have that ability to do the electrical current evenly. So it'll give you an arrhythmia. So they put a pacemaker in to compensate for that. And then there are also some medications like beta blockers that can make your heart beat too slow, but you need the medication for other reasons. So again, how do they take care of that? Well, they put in a pacemaker. Now, an ICD is different. It's an implantable cardioverter defibrillator. And I would urge you guys, if you have never seen a cardioversion before, it's pretty awesome. Not necessarily for the person that's having it done, but for everybody watching, it's pretty cool. And it's ultimately what they do is, you know, in the movies when they shock them and they give them like 200 joules, you know, and that's ultimately what they're going to do to you, but you're not dead. So they give you medication and everything, kind of put you in a stupor, and then they, boom, they shock your heart, and hopefully it knocks you back into rhythm. Why do you need a defibrillator? Your heart beats too fast and it's out of rhythm. Okay, and also sometimes people have had a heart attack, so there's damage to the heart muscle after an MI, and so therefore it can't do a steady rhythm. And they have also pacemakers and ICDs in combo packages. So maybe you need a pacer to keep the heart going steady at an even beat, but it also gets out of rhythm, and so it needs to be zapped, you know, to keep it going if it gets too slow. And that's what an ICD does. Now, as far as the coding for those two, let's talk about what's happening in the heart that would constitute you needing them. This is what it reads off of an EKG strip. You have the T, the Q, the R, the S, and the T wave. That's what those are called. And if you want to study more of that, it's pretty fascinating. I really enjoyed it many moons ago, and got to where I kind of thought I knew more than I probably did, but I enjoyed reading and studying these and looking at EKG strips. Ultimately, at the P wave, that first wave, is when the heart activates, okay? And so that's that first squeeze of the atriums. And then you have the QRS, which is it dips down, it goes up, and then it goes down again, is the ventricles, the bottom of the heart squeezes. And then the T wave is when it rests. So you have the P wave, bam, it squeezes, QRS, bam, squeezes on the bottom, and then it let go and relaxes, and that's the T wave. Because they know that if there's ever a problem, they can identify it on the graph. So a normal heart beat, that's what a normal heartbeat looks like. If it's too fast, again, you can see that your R waves, everything is too close together. And this is a graph. That's how they check it. Now, if it's too slow, again, they're too far apart. And then if it's irregular, then it's pretty obvious, right? You have powerful R's, and then you have weak R waves. And then you have P waves, and the T waves can be out of sync. And then you can have ripples and flutters and stuff like that. But ultimately, that's how they know what's happening to the heart. Now, if we scroll down, oh, just a second here, I was trying to grab that image. Don't want to do that. This is what it looks like when a person has a pacemaker implanted. Notice that it changes the wave, but this is what it's supposed to look like. And that means that when you see this T wave, not the T wave, the R wave, the up, notice that it doesn't look the same. That's because none of those look the same, because there is an electrical pulse going. It's like a drum beat that keeps it steady, you know, a steady drum beat. And so it's literally mechanical, and that's why it looks different. And then you'll even notice the bottom one is the blip or a spike on the EKG is how they know a person's got a pacemaker. And then they can tell if the pacemaker is working properly. Now, this is a little bit harder to see, but it was such a good graphic. So this is what it looks like when you need an ICD. So if a person was having a heart attack and their heart is not beating properly, and they put now they're just stickers that they put on somebody. It's not like it used to be where you had to put gel and all this other stuff. They just put these giant stickers on you, and it will give you this reading, and that reading will tell you that, okay, the heart's not beating efficiently. The atrium and the ventricles are not doing their job. It's just a flutter, right? So we don't have our peaks. And when you see waves like that, that tells you need to defibrillate the person. As that's how you got these external defibrillators that in places of businesses, and literally that just walks you through it, even talks to you now and says, we are in VTAC rhythm, blah, 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 or whatever. And that it does all the talking. It even tells you when to push the button. So you push the button, or if you have an ICD implanted, it knows, it recognizes this is the issue, and then it zaps you. It literally just zaps you as if somebody was doing the paddles, and this is what it looks like after they zapped you. So you can see the zap right here, and then boom, 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 it goes back into rhythm, and then it's going on to explain other things that it can do. But it's really fascinating. You can go in and just Google image EKG strips, and you can even Google EKG strips ICD or defibrillator, and it'll let you see when they zap somebody, and it'll go bzzz, like that, and it's really cool. Looks like an earthquake. So now, see, I added a little bit more. A couple codes that you should be aware of is Z9 5.811, because it risk adjusts. If a person has a defibrillator, an ICD, or a pacemaker, they have a presence of a heart assistive device. And it's really, really important that you capture that for the coding purposes, especially for risk adjustment. So you can have a VAD, a ventricular assistive device. You can have a pacemaker, which they call a PM. You can have an ICD, and you can also have a Watchman, which is a special valve that's placed in the heart. Go Google that. It's really cool to look at how that works too. It doesn't allow black flow and stuff. Now, how do we code the CPT codes? If you are going to put in a pacemaker or an implantable defibrillator, and you're putting it in, here is an example of the VAT technique. So you would underline and insertion. How are they inserting it? Which you can't see my underline because I think it's covered up with the highlighter. And then everything else after the semicolon is highlighted in yellow. That's the BAT technique. So what are we doing? We're doing an open incision, and we can do any of these approaches, right? But that's putting the pacemaker or ICD into the body. And there's a process to do that, because they got to make a pocket and they got to place it in there, et cetera, et cetera. But there are other devices as well. They're single chamber, they're dual chambers, and I went ahead and put that on there for you so that you can look at those. And that being said, when you're in the club, you get access to all these answer sheets. Do note, though, that these codes report insertion of the electrodes only, not the generator. That's not the little power pack, the power cell. And now they've got them down to where they're not much, they're about the size of a silver dollar or a little smaller. If you code endoscopic exertion, it's 33203. It's a little bit different code, because there we're doing open, and down here we're doing endoscopic. Got to pay attention to those. And then it lists if we're going to do endoscopic opposed to open. These are the different things that could be coded. Okay, so you've got insertion of a new or replacement of the pacemaker with the electrodes. Electrodes are the wires. Insertion, removal of pacing, cardioverter, defibrillator, pulse generator, etc., etc. Removal of the pacemaker and pulse generator, and it says with replacement. And then the other one, notice that it was just removal of the pacemaker only. You got removal of a transverse pacemaker electrodes, just the electrodes. Then you've got removal of the epicardial pacemaker and electrodes by thoracotomy, which is opening up the chest. Removal of a single or dual chamber pacing, ICD, and then you have removal of the pacing of the ICD plus the generator with replacement of those components. Now, all of that is ranges of codes, and I didn't want to put all the codes in there for you because it is literally just the title in your manual, or if you're using an encoder. So what are you going to look up? You're going to be looking up either, are you going to insert or are you going to remove? That's what you need to know. And then you're going to go in and say, what are we putting in, taking out, or what are we putting in, and are we taking out or replacing ultimately? And that's how you code those. It's fun stuff, but it does get confusing because of all the different things that could be done with them.
Thank you, ma'am.
You're welcome. Ooh, insurance.
Insurance. You love insurance. Why don't you take this one?
Flying tonight.
So somebody put in a question wondering about their instructor that they had helping them prepare never covered Medicare. So is there any insight as to what's necessary for the CPC exam? So just going to go over a little bit of basic information about the CPC exam. And it's geared, of course, towards coding of CPT and ICD-10. So that's the basis of the CPC exam. On AAPC's website, this is what they currently list as the questions contained within the CPC exam. 10 questions stemming from each of the series of 10,000 to 60,000, so integumentary to eye, ear, adnexia. Then 10 questions on Enm as it currently stands. 8 anesthesia questions, about 10 radiology, about 10 path lab, about 10 medicine, 8 medical terminology, and 8 anatomy. So of course, all tests are different. I think they have about 16 versions of the CPC exam. So of course, you're not going to get the same one as your neighbor. If you take it 3 times, you're probably not going to get the same test all 3 times. So these are approximations because they might differ between exams. So there will be 10 separate questions about ICD-10-CM diagnoses and 5 questions on HCPCS. There'll be 6 questions regarding coding guidelines and another 5 dealing with compliance and regulatory. That's where you're going to see any questions dealing with Medicare as part of those 5 questions out of, what is it, 150? I forget what's on there. I think it's 150 questions. So within that category, they say you will have questions that could pertain to services covered under Medicare A, B, C, or D, applying coding to payment policies, place of service reporting, fraud and abuse, NCCI edits, NCD or LCD, which are national coverage determinations or local coverage determinations, HIPAA, ABNs, and RVUs. So out of all of that, they will pick 5 and put it on the test. So if you have one about Medicare, possibly. So you'll have very few dealing with actual Medicare insurance. But just to go over what they did mention could be any of those 5 questions that deal with Medicare. I thought I'd go over just some basic information because anything, of course, is not going to be that in-depth on the CPC exam dealing with Medicare. So Medicare does have 4 parts: Medicare Part A, B, C, and D. Part A is your hospital inpatient coverage. Part B is the outpatient and physician fee schedule coverage, so medical billing. So you go to the doctor, you go to a facility and have an MRI, you have a colonoscopy done, that surgical procedure, all of that's going to be billed under Medicare Part B. If you're put inpatient in the hospital, that's going to be Part A. Part C is what they call patients who are using the Medicare Advantage plans, like Aetna Medicare, United Healthcare Medicare, Humana, other insurance carriers that offer Medicare coverage. It's very confusing for people because the patient technically still has Medicare, but they're using another insurance in place of that. They're having another payer pay their claims. Medicare Part D is your prescription coverage. So if it's about any of those, it's kind of the basic gist is there's 4 different parts and they each deal with a different component of care for the patient. Medicare's payment policy is a fee schedule basis for Medicare Part B for those doctors and outpatient facilities, and a prospective payment system under Part A. There are many prospective payment systems. There's inpatient prospective payment systems, outpatient, skilled nursing, all sorts of prospective payment systems. And under the fee schedule, Medicare will process your claims and pay the physician 80% of what their fee is, with the patient or their supplemental insurance responsible for the other 20%. So possibly a question might deal something like that. NCDs and LCDs are national coverage determinations and local coverage determinations. So just as the name states, CMS as a national carrier may have a coverage determination of what types of services they might cover, or the local MAC contractor could have determinations for the local area. Now, MAC contractors may deal with groups of states. So I'm under Novitas Solutions. So we deal with Pennsylvania, Maryland, Delaware. I'm not sure where else. But then they also do like Oklahoma, and they also do some other states in the middle of the United States where WPS has some areas, and First Health, and there's a lot of different Medicare contractors out there. So it may be a group of states that is a local coverage area. So what one has, maybe Novitas Solutions, WPS, they might have a coverage determination for a particular procedure that I may not have, or that somebody, another contractor may not have. But if there's a national coverage determination, that goes by everybody. Local is for a certain area. If the determination, if it does not have an NCD, then the LCD has to be used. That's what's going to prevail. If neither a national or a local coverage determination exists, then you'd be uncertain as to whether that service would be covered. So that's where one of those final components of the ABN comes in. An ABN is an advanced beneficiary notice. And the reason they call it advanced is because that patient needs this notice given to them before a procedure is performed. They have to agree to pay for it, and they have to understand why they would be responsible for paying for it. They don't have to sign it, and they don't have to get that service. So that ABN is like a waiver of sorts, identifying that the patient is aware that their service may not be covered and they may be responsible. Any question about Medicare is going to be pretty basic. They're not going to ask you specific Medicare guidance. They're not going to ask for what place of service does Medicare use in telehealth. Well, okay, it's not going to be that specific. It's going to be a patient has hospital coverage, what Medicare plan is responsible for hospital coverage. Kind of something, you know, pretty basic. There are other exams other than the CPC that are going to have questions regarding Medicare or other insurance carriers on them. The COC exam has 20 questions that deal with payment methodologies, and Medicare is included in that. So some more questions that if you're going for a COC, you might need to know a little bit more information about. CIC, the inpatient, has 9 questions about regulatory and payer requirements, such as identifying those services covered by Medicare and the ABN. And the CPB, of course, the billing exam, has 44 questions out of 200 that are about the types of insurances, and then another 25 that deal with Medicare or things particular to Medicare, like incident to billing, national coverage determinations, and local coverage determinations. Some things that are more specific to the insurance carriers are going to be found on the billing exam. So CPC you wouldn't have to worry too much about. I do know that HEMA's tests do include more insurance questions than as in comparison of the CPC exam. So AAPC and AHEMA have a little bit different stance on it, so you may need to know more about insurances and their a little bit more about them for an AHEMA exam.
Good to know. Good to know. Okay. Hey, let's go ahead and do a poll real quick before I do my last one. How about, are you a member of the CCO club? So you can ask yes, or you can answer yes, no, I decided not to join at this point, or no, didn't know about it. Is it important? And I'll tell you, yes, it's important because it gives you so many perks. Like getting to a copy of our answer sheets, being able to access those. Yeah. So we'll tell you more about that as you're voting. Looks like they're coming in pretty, we haven't made you go to sleep yet. The CCO Club, we mentioned before that it gives you CEUs, but they're fun CEUs. I like to always say that because sometimes when you buy CEUs, you don't want to be listening to a robot. You want to, and you want to get CEUs for things that are pertinent to what you're learning or what you want to know. You know, if you are like Jennifer, of course, auditing CEUs, you've got to get those. She'll have to get CEUs for her new Credential specialty CEUs. And so we work real hard to make sure that we have a variety of them available. Hey, I'm going to close this poll. Are you ready? 5, 4, 3, 2, 1. Boom. Yeah, that was fun. Okay, let's share it. Hey, this is pretty cool. We've got 44% of you guys are members of the CCO Club already, and it's even. 29% no, I decided not to join at this point, and 27 said no, didn't know about it. Is it important? So, hey, go if you guys are joining us on LinkedIn, Facebook, or YouTube, chat amongst yourselves and the advantages of the CCO Club. I think that you'll find that it's extremely helpful. So let's see. I don't need to share that anymore, right? Did I hide it? No. Did I share it? Maybe
Yeah,
I didn't share it.
Yeah,
I did. Okay. Okay. Now I hide it. Okay. Got it. My mouse has me confused. That's what I'm going to blame it on. I had to get a new mouse. All right. So this particular topic, guys, I got you some pictures. We had a question come in that says, when a stage 4 pressure ulcer is healed, it should be classified as healed stage 4 pressure ulcer. This conflicts with the statement, no code is assigned if documentation states that the pressure ulcer is completely healed. And then they went on to say some more. So let's go that over real quick. It was actually a little bit longer. So I'm thinking maybe the difference in the conflict is where it states should it be classified is not the same as saying should it be coded, but I'm not sure. Seems like you wouldn't code something if it's healed, but in the physician document, it was explaining that even when the deep ulcer is healed, it will have left damage to the muscle etc. So this leaves me confused. Will you please clarify? Well, I can do that for you. It's actually a pretty simple answer to the question, but I went ahead and pulled a pressure ulcer code. So really commonplace is the backside on the buttocks. So if you've got a pressure ulcer by site, and then they'll want to know if there's laterality to it. So this just happens to be the right side. And then they're going to stage it. And you have the choices of unstageable, meaning that usually you just can't see. Either there's it's called eschar over the top of it, or it needs to be debrided and cleaned to be able to actually see how deep the ulcer goes, or it's a wound, and sometimes it'll even go under the top flap of skin. So you'll have the skin like this that you can see, but then underneath here there's actually it goes deeper. So this is just a thin layer of skin. They debride that, and then they can actually see how wide it is. So they measure it by width and depth. And so you have stage 1 through 4, or you have deep tissue damage, and then you have unspecified stage. Now, unspecified means they didn't list it, okay? But unstageable is different. Unstageable means, hey, I can't tell until we get in there and really start cleaning it up and finding what's viable tissue and what's not. So every body area that commonly could have a pressure ulcer has a code. And and you've probably seen several times the little graph, and they'll have like a body, and then they'll have circles on all the places of the body, like the heel, the back of the head, the elbows, the hip bones, and stuff like that. That is common to have a pressure ulcer. So again, these are the basic codes that you would use if you had a code, but that's not the question. The question is, if the pressure ulcer is healed, how do we code that? Well, I understand the confusion here because it's kind of based on semantics, and I'm sure reading it just got confusing. So I pulled this year's coding guidelines, and if you look at this year's, the 2020, on page 56 of 121 of the guidelines, you can literally turn to that page, and number 4 and 5, it tells you there's only one exception to coding a healed pressure ulcer, and that's if the patient is an inpatient and is being discharged. So if the patient is admitted with a healed pressure ulcer being noted, you don't code it, okay? Because you're right, it's healed, you wouldn't code it. You can document it, it'll be documented, and that'll be on the record, but there's no code. There's literally no code for a healed pressure ulcer. That also answers the question. But although if the patient is admitted with a pressure ulcer, and during the time of the stay, the pressure ulcer is then healed, so they're inpatient long enough that it's healed, what do? Well, then the exception is you go back and you code for the at the time that the patient was admitted. So there is a exception to the rule. Okay, so if it's a stage 2 pressure ulcer and then they're admitted and then that's completely healed in 2 weeks when they're discharged, then you go back and you on the discharge, you code it as a stage 2. So if a pressure ulcer is documented as healing, not healed, then you use the example that I gave you before, that L code that you use. But once the ulcer is healed, there's literally no code for that. And you notice that because when I showed you the list of the codes that were available to you, there isn't one for a healed ulcer. So what do? Let's look at the question again. It says, when a stage 4 pressure ulcer is healed, it should be classified in the documentation as healed. That doesn't mean coded. That means when you document it, you're stating this was a stage 4 pressure ulcer and it's now healed. documented or classified in the documentation, not coded. And then it goes on, no code is assigned if documentation, because it's been classified, states that the pressure ulcer is completely healed. So that, again, it's a little bit of the semantics that's involved. What I think this person was reading is that, hey, you do document, and the clinicians can document it, and that is you can code off of what the clinician staged a pressure ulcer at. But this is just documentation. So you classify that this was a stage 4 pressure ulcer of the buttocks that healed, and then no code is assigned to that documentation. Again, healed while inpatient, then you code it upon discharge what it was staged at upon admittance. So that was pretty easy and straightforward, but it does get confusing, and I understand sometimes you just need somebody else to look at it and clarify it for you. So what I did was I went and found some more pictures, and this is a first visit with dressing change of an ulcer of the toe. This would be really scary if you had a diabetic, right? And then notice that on day 8, full closure of the wound. So that's good, right? And then let's see, we have this next one that you notice that they're giving you they measure everything, and they also do depth. They have some pretty cool ways that they measure, but sometimes they'll take like this Q-tip and lay it down in there this way, and then they'll pull that out and then measure the Q-tip. And then here is on day 135, 74 days after closure. So it's a nice and healed ulcer. Here's another one that I believe that is, actually, I don't know where that's at on the body. I couldn't quite tell. I thought that it was at first like the back of the knee or the elbow, just a skinny person. And then notice here too, where we have a pretty significant ulcer, and then it's healed up, and it will leave a scar. Yeah, the scar will remain. So there you go, some great pictures. Go out and Google image those pressure ulcers if you have the stomach for it. It's a lot of fun to see the progress and how they are healed. All right, guys. So more information about the CCO Club. Yeah, a question had come in, how do I know if I joined or not? You can always send a message to the help desk at cco.us. They can answer any questions for you, but you also will not have access if it didn't work. So ccoclub.us/club, and you get all these great perks in the club. Great time to take advantage of the sale also. Ooh.
So did you get
time for this
value
poll?
from tonight's CCO Q&A webinar? Yes, we do. Why don't you launch that guy? Let us know if you enjoyed tonight. Let us know in the Facebook chat as well as the YouTube chat. Like to hear you raise your voice. If not, if we could improve things, also let us know. We won't hold it against you, not at all. We're always trying to improve. Pretty simple. Yes, no, or not sure.
You make us better.
Pretty big in our field is feedback. You know,
Oh, yeah.
dealing and coding, feedback, it makes us better coders. So, you know, never look at it as a bad thing. So
being audited is a good thing. I enjoy being audited. Okay, man, you guys are not asleep. You went through it pretty fast. So I am going to go ahead and close the poll and share it. And oh my, thank you very much. It's at 100%. Yay, yay. So the way we work this, guys, is that you submit your questions that you need help with. And a lot of times we'll have questions that come into the club and they need a little more research, and we'll say, hey, can we do this on a webinar? Because we want everybody to be able to take advantage of your question. It'll help others. So please let us know the questions that you have, case studies and stuff like that. They can be redacted. We appreciate it. You make us smarter. We also have a survey. Boyd, did you want to tell them about the survey, or did you want me to tell them?
Just go to this link. I'll pop it in the webinar chat here for everybody, and you can take the survey and let us know in a little bit more in detail how we did tonight. I'll grab that right away. And I think we are close to the end here. Oh, we should be doing our drawing right next. Is that the next one?
Yeah. Did the name already get picked?
Yes.
Did they draw it yet?
We do.
Okay.
And our winner tonight is Meg Ross. MEGROSS.
Meg Ross.
Yay.
Congratulations, Meg. So you get to choose. You can take a Blitz video package. You can take a 1 year of the CCO Club Basic that we were just telling you about, or you can do, and notice it says 1 hour session with Alicia, but you can do it with any of the SMEs if you want. Again, congratulations, Meg. And we're ready for our chat questions. Did we do good on time, Boyd? I wasn't looking at the clock.
Perfectly timed. We're perfect time.
Yeah, perfect.
So this is
Right,
the official end of the webinar. These are your questions. Hopefully we've got a couple in the chat that our team has taken, and you may not have the right one there, so just make sure you're clicking the refresh it, put it that way.
Okay, let me just refresh.
Hover over it and see if actually it's also in the link in the chat, in your chat. You go to webinar chat.
Okay.
Yeah, you're good.
All right. So thanks, Sylvia, Lori, for behind the scenes and taking care of all that for us. Let me take my camera off. That'll make that load faster. And I need to be looking at my mug while the computer is struggling to open that stuff up. And I'm looking at the chats. Thank you for telling us in the chat that that it was helpful.
I'll read it off while we're doing that.
Okay.
Alcohol and tobacco is the headline. What would have to be documented to use alcohol cessation and tobacco cessation counseling codes? Have seen some physicals want to use codes, but a patient has an HX of alcohol, or I'm laughing because I'm trying to.
I'll take it over if you want.
You did a good job, but
You're doing good, Boyd.
Yeah. So they've seen some physicians who want to use the codes, but the patient has a history of alcohol or tobacco abuse. So in this scenario, would it be a motivator to the patient to stay, quit, or just a way for the providers to detail all the medical risks of abuse or nicotine dependence? That was a mouthful.
Well, it's a time-based code. You guys, so if they're documented, they have to document how much time they spend, and it's a minimum of, isn't it a minimum of 15 minutes, or is it 10 and 15? I can't remember.
3.
How many?
3.
3? Oh, okay. I used to have the code up on my desk on my notes that I keep on my wall. Yeah, my stickies, but I think I'm doing risk adjustment now, and so I don't need that.
Well, I did look
because there was a provider. Okay. Yeah. We had this, while you're pulling that up, we had a provider that I was working with, and he did this beautiful documentation about, because he was really serious. That was something that was on his heart to really, help people. Great documentation, but he refused to document how much time. So he never could use the code. We wouldn't give it to him.
So it's recommended by it's actually, one of the links I found was the American Academy of Pediatrics. So interesting, but definitely you want to start young. If kids are smoking, you want to get them off of smoking, especially now with Juuls and and even secondhand smoke is just as horrible. So they kind of suggest, when should you counsel people? If their parents or they smoke, counsel preventing exposure to secondhand smoke. If a new patient, or I'm sorry, a new parent, we want to make sure that they assist them to avoid smoking during pregnancy, of course. Pre-adolescent or adolescent is not a smoker, counsel them on not starting to even smoke. So, what they say is, how should you counsel them? Brief counseling, delivered in as little as 3 minutes. Focus on the child. They have the 2 A's and an R, which is ask and assist and then refer. Or they have the 5 A's, which is also useful, which they also talk about for alcohol cessation or counseling. The 5 A's, which are ask, advise, assess, assist, and arrange. And the American Academy of Family Physicians, as well as the pediatrics, had a lot of information. I mean, just in the time that the question was posted until now, I Googled and got a lot of hits on it. Medicare does pay for it. There is 8 visits that you can pay, that you can send within a year, within 12 months. So there's a lot of information out there about it.
I think Medicare, I don't know, was it $26? I think it was like $26 or something that it pays out. So, it doesn't seem like very much, but this particular provider, like I said, he did it all the time. It was something that he really felt was important. And so in the scheme of things, in a month's time, that's a lot of revenue and time that he puts into his visits that he would have gotten compensated for. So, which would have been maybe the ability to get more pamphlets or something to give to the people, resources.
It is greater than 3 minutes up to 10 minutes. So
up to 10.
And I think definitely anything with time, especially going on, time changes, especially right now with COVID time being used for face-to-face telehealth, things like that. Yes, document that time. I mean, one huge thing to keep in mind is those EMR systems also document the time. So if you have a patient who checked in at 9 o'clock and checked out at 9:35, you couldn't have done 45 minutes of a visit with them. So, when they say half of my time is spent greater than, 45 minutes or whatever, and it's like, no, they weren't even here that long. And in that same time, you had 2 other patients who came in. How could you have spent that amount of time with them? So, Debbie, definitely marking time is a very good thing to keep in mind.
Debbie mentioned the time also, and then she says you also must document what will be done to assist with cessation. So she was right on top of it. Let's see.
Definitely anything with counseling, you want to, you want to say what you talked about. And of course, yes, the outcome of what you expect, because a lot of these things are just like those assessments for neurophysiological tests, they're looking for what is going to come from these things. So, what's your treatment plan? What's your idea as to why you're doing it?
Right. Gloria had a question, says, do you have something on LCDs, how to use the Medicare website to check what diagnoses are covered, etc.? We do have a video on that in our YouTube, and I know Jennifer has talked about it several times on our club or student webinars as well. But the information's all, if you have an encoder, we use Find a Code, and it's all in there too. So
it's
learning how to use it.
Definitely on the, like I said, we were part of Novitas or Novitas, whatever they're supposed to be called. They are in the process of converting all of theirs. So you used to be able to find them, but now they're doing like an archive, so where they'll all be in one spot. So you may not be readily accessible, and it may not look the same as it did before. So yeah, but they should
Sandra
be
wanted to know if
easy
she
to
can
find. Yeah. Go ahead.
Mhm.
Sorry.
You can Google it. Sandra wanted to know if she could use her 2019 manual for the 2020 testing. And no, that's never a good idea. I mean, you could. You got to write in all the changes, but it's and we've done some videos on that as well on YouTube, but it's not a good idea. If you're going to invest that much money that it costs to take the test, and the manuals are expensive, but you know, why second guess? I mean, you can miss like 40 questions, and those you might miss 3 because you didn't have the right manual. So gosh, you know,
Yeah,
let's see.
especially the way tests are going right now. Do you want to run out and buy a 2020? If people might only be testing November and December or something like, you know, it just, I would kind of wait till you get closer to know what an actual exam date is looking like the COVID.
Yeah,
And then see if you can borrow somebody. Go to the chapter.
that's right.
You don't
That's
have
a good
to
idea.
purchase it if you're just using it for the exam. And I understand people's dilemma right now, especially with money. But, you know, see if somebody in your chapter has a set that they can loan to you. It may not have all your markings in it, but, you know, it'd be a current
CPT,
version.
if you had to pick between the two, I would definitely get my own CPT manual because it's the one you're going to bubble highlight. And if you do the work, then you're going to know your manual better. And then borrow the ICD, you know, because that one you don't make very many notes in. Let's see. Mari said, excellent webinar. I'm new at this and enjoyed it and understand that somehow I'm an RN with 0 background in coding. Does the inpatient coding course have all of the things I need to know to pass the CPC exam? No, the inpatient course is very different than the course for the CPC, which is an outpatient credential. Now, because you're an RN, you could probably get in a little faster working inpatient, but inpatient is harder to get in as a new coder. But again, as a clinician, you've kind of got your foot in the door, and they might even have you doing some CDI work and stuff. But no, it is a different course. Ours is called the PBC course. So I would suggest that you take it first and then the CIC, because it gives you the 2 main code sets that you'll be using in any type of coding. And plus, you can do inpatient coding as a CPC. It's just not very common. I mean, there's other code sets you got to learn to do inpatient. I think we got one more. Sandra said, I already bought the 2020 version because I'm learning how to code. Good. Very good.
Yeah. Now, there was one, just a comment by Wendy that as a CRC and a CPMA, it's hard to find CEUs. So she usually winds up purchasing. And yes, that is a problem. I mean, my girlfriend is a CCC and a CIRCC. She has to spend like $700 getting them from Dr. Z and you know, to get the cardiology ones where it can be difficult. But CPMA is actually one of the, it's typically offered at chapter meetings as a CEU. It's typically one of the credentials that they give. And just know that when you go on your AAPC site, you can designate to which credential you want to assign those CEUs to. So if you have a couple that you see that you did that are offered for CPMA, maybe use those for your CPMA, and then that way other ones you might get are only good for your CPC or something. So, and unfortunately, like Alicia said, it is an investment. So we may have to contribute to another organization in order to get the CEUs, but that's where our knowledge is going to come from as well. That's going to support what we do. So,
and that's why we try
kind of that two-way
really hard to keep our CEUs valuable and pertinent to what people would need. And we mark ours too, to let you know what other credentials they'll be able to be used for. Sandra wanted to know, CDI is clinical documentation. And they like to do RNs to do that. Hey guys, you've been wonderful. It's been a lot of fun, and I'm glad that COVID doesn't affect the way we we work because we're all remote. So we're here
Just
to help
affects
you
the way
guys.
we look with our long hair.
Yeah, I was like, my hair. I said my hair's already past my waist. I can't hardly believe it. That's why you're piled up high on my head. And Boyd's got a beard, and you guys, we probably most people find us on YouTube. Wouldn't you guys say that most people tend, if we ask this, oh, we found you on YouTube, and
Word of
that's
mouth.
because
Yeah, YouTube wouldn't
word of mouth.
Yeah.
Boyd makes sure that he's taken pieces and parts and making, information. That's all free content that's on YouTube. And we've got,
Well, let me update that because I didn't update
Okay.
this week. So we're actually very close, like 25 from 30,000 subscribers.
Oh,
Wow.
Looking to see if we could give a prize out to the 30,000th person. But I don't know if I can even download the subscribers that we have. So
That would be really cool.
if you're in YouTube right now, if you haven't subscribed to the channel, please do. And if you are anywhere else in the world, please subscribe to our YouTube channel and push us over the 30,000 limit, the 30,000 subscriber count. Put it that way. And these videos we're live streaming all the time, and when we have time and the energy and everything else that is necessary to put these into YouTube, then they're going in there. So you'll always be able to find us in the evergreen
Almost
area.
a decade. Yeah.
Yeah, 2012 when this channel started going now. So we had another channel before that, but this one's been going through 2012.
Oh, Whitney loved your Mad Libs game. She wants another one.
Oh, well, we'll try that again. We'll have to streamline a way to make it a little easier to do live.
I was thinking
remote.
that you could do that with a Google Doc or something like that. You know what I mean?
You're right.
Make
Oh
it
yeah, that's smart.
And
What's the name of the channel again?
That they're talking about, there is a YouTube video that maybe someday we'll actually take the actual content when you were reading it out, but it's in YouTube. It's left from last week, so if you want to check it out.
We did it for the we did it for our CCO Live, right? We didn't. That's our fun. That's the fun night where we do less more casual stuff and everything. But we'll come up with something. But we also that night offered a bunch of information on how to have games at your chapters and stuff. So
even virtually. So even a virtual chapter meeting. So yeah.
That's right. We're also on Facebook, guys. So make sure you get out there and look at our Facebook channel and share with your friends. Lori's always letting everybody know what's happening. She comes up with like word of the days and things. Hey, we do remote presentations, but now we're not doing any live remote presentations right now. And we're not traveling. Because this is what I usually say. If it's close to Jennifer and I, we'll just come to your chapter. We'd love to do that. We don't do that right now. So we have some really great recordings, and pay attention to the CCO website, this remote presentation site, because we have some new titles coming up. So let us know if there's something that we can help you with in that, because you guys are all having remote. Don't forget the survey that Boyd put the link in. Don't forget the club. We can't talk about that enough. The club has been really, really beneficial to I'm always learning something from a question that came up. And I think that's let's see, more on the YouTube.
Yep.
And then all of our pretty resources. So look at all that stuff we offer you guys.
And again, all this information is available to club members after we're done with the transcript and everything else. So we try to make sure that we splurge for those guys. Cool.
Club members are special.
Happy learning slide, I think we're ready for. So hopefully you guys are healthy and wealthy.
Happy, healthy, wealthy, and happy. Paulette made a good, she goes, when will you be offering a prize for longtime CCO members? Ooh.
Because Whitney said she's 3 years now, and I think Whitney's
at
every single event, I think.
Yeah, we might have to. Yeah, Whitney manages to
I think we should hit up Jesus to get those people a shirt or something.
Find some kind of swag. I want that crochet hook that Alicia plays with while she's doing presentations.
Ready for them, or She's writing.
Oh, Paulette since 2012. She's got
Wow.
Whitney
See,
beat.
I got another card ready to. I got a whole passel of cards that I wrote out today. So,
Thanks.
well, guys, you know, we appreciate you. Thank you so much. Don't forget to let us know the questions you want us to cover, because you're the reason we do this. That and to feed our families, so we can buy more lipstick. No,
Video gear and Michael. Yeah.
More crochet hooks.
more crochet hooks. Mama needs some new yarn. Bye, guys.
Yeah.